perform the procedure and visualize the ear canal. And we also train ear professionals around the world in endoscopic ear care. I have a client here who actually attended last Friday, so a week ago. They were assessed and treated by a private ENT consultant a couple of days prior for an ear infection in both sides. When they attended last week, the ear canal was far more heavily swollen, so there's a lot more edema, swelling, inflammation. The ENT consultant provided some ear drops for the patient. I think it was Gentasone HC drops that contains gentamicin. And I think a couple of days after the patient using it, he contacted myself saying that he felt as though the ENT surgeon had put something in his ear, addressing it, it was blocked and it was really uncomfortable. So agreed to see the patient. Patient is probably watching this, he's a YouTube fan, so he travelled a fair distance to attend the clinic last Friday. I think I've probably got the video, but the ear canal was extremely inflamed, far more than what it was today, and managed to clear a lot of debris actually, but there was this debris that we're trying to remove today that was impacted on the eardrum that I couldn't just get access to. It was just not possible. The ear canal was too heavily swollen. The patient decided to come back to me personally to have it removed today, so that's not a problem. I wasn't sure. I was a bit worried when they booked in initially. I didn't take the booking myself. That they're coming back in a week, because I wasn't sure whether a week would be enough given how swollen the ear canal was for the drops to do their tricks. But the ear canal is widened now, so it's still very swollen, but I can see immediately. And we've got this plug. If you probably saw before, I was searching a lot of debris, a lot of infected discharge. And we've got this infected debris that's lodged in the isthmus. The ear canal has two narrowings, and a narrowing in an orifice is called an isthmus. The first narrowing is where the bony part of the ear canal and the cartilage part, so the osteocartilaneous juncture, at that point, so that's probably about 1 centimetre into the ear canal. And there's a second narrowing about 0.5 centimetre there or thereabouts near the eardrum called the isthmus. The ear canal narrows at that 5 millimetre distance away from the eardrum, then it expands again, it protrudes outwards, and got this infected debris lodged beyond that isthmus, and on top of that the ear canal swollen. So you can see I wasn't able to use a standard Zollner suction probe, it's just the ear canal's just too swollen, so I was using a fine end gauge. The patient had a repeat prescription, so they actually saw ENT again a couple of days ago. I'm not sure whether, I don't know, it's a couple of days ago, so I don't know, but I didn't want to pry too much as well, but I think the patient just preferred getting the medication from the ENT and having the procedure performed on myself, because I'm pretty sure, I mean, it could have been done there, but been given a repeat prescription for another 10 days, which I've advised the patient to continue because the ear canal is obviously still infected, so there's a chance that if the infection is not treated efficiently and effectively and quickly, that this discharge can come back out and resurface again. So it's just lodged, it's really difficult to remove. There's a gap there at the back, so you can see some of the eardrum's exposed. In fact, I think I'm just going in with a normal Zollner suction probe. I'm just seeing, because the fine end just wasn't powerful enough. So I'm just about managed to squeeze it into the ear canal. It's quite a smelly ear as well. When I was performing the procedure, although I've got a mask and visor, you can still of the olfactory evidence of the infection, you can still smell it. So I'm just trying to using an ear hook. I just don't think this is going to come out any other way. A forceps, the debris is too squishy, and it'll just bite away. And in fact, the ear hook initially pushed it further in. I've kind of made his ear slightly worse. I've lodged it further in. I just couldn't get behind it. It's so deep. Sometimes what's good is when there is a bit of swelling, because obviously, as you probably know if you've been watching my videos, the inner 2/3 of the ear canal is skin on bone. It's a very thin layer of skin that's directly coating the bony part, which is very sensitive. Sometimes, not always, but sometimes when someone's ear is infected and swollen like this, there's a lot of swelling, it kind of provides a buffer effect. So I'm able to use some of these instruments sometimes, not all the time. Sometimes the swelling itself is really tender. But for this particular patient, I found that it wasn't. Just using a fine end, just had to bring this forward. You can see it's a bit squidgy. I'm not getting the right suction grip, and just the fine ends is kind of imprinting within the soft gooey wax. And actually, initially that ear hook lodged this wax further in. So just using some sodium bicarbonate drops. I wanted to avoid sodium bicarbonate because sodium bicarbonate is water-based, it's alkaline. The ear is naturally acidic, and when people have ear infections like this gentleman does, the pH level changes from acidic, so that the average pH, the range should I say, is between 5.4 and 7.1. That's what a normal ear canal pH level should be, so slightly acidic. But when the ear is affected, it turns into an alkaline, so pH between 7.1 and 7.8. And a lot of these ear drops, they are designed to re-acidify the ear canal. So a lot of the drops have got a very low pH. So I think acetic acid, for example, like a vinegar solution, it's 3.8. So yeah, sodium bicarb, because it's water-based, water can sometimes aggravate infection, and it's the alkaline solution itself, we're trying to re-acidify the ear, but olive oil drops just wouldn't have worked in this case. It's just not the right type of wax or debris to use it on. Sodium bicarb could have broken this down. That's what I was hoping to break it down. Olive oil kind of softens the wax, it binds it together. Sodium bicarb doesn't dissolve, but it breaks it into little pieces. When you suction it, it kind of tears away into little pieces, and that's what I was hoping. There's the patient's eardrum, just so you can see the posterior quadrant, and you can see the eardrum's wobbling as well, so because there's some debris on top of it. But the patient was really still, not experiencing any discomfort whatsoever, so that gave me confidence to continue. So obviously the ear is a lot better at this stage than it was right at the beginning, so you could hear it very well indeed, but I really wanted to get this out. And you can just see now how much swelling there is. You can see the ear canals are really enclosed, the wax, this debris is engulfed within the swelling. I'm just trying to wriggle it out. It's just getting trapped at that point. So I had a bit of a bad experience with the ear hook because I kind of lodged it further in. It's just so hard to get an ear hook inside there because it's just so narrow, there's not much space. But eventually, it's what I actually used to remove the... Sorry, it's been a long day, just yawned there, I do apologise. Yeah, and eventually it was the only instrument I could use. And here we are, so I almost touched the eardrum, I had no choice, and I did pre-warn the patient it might be a bit uncomfortable, but actually when I approached it, I just dug it in, so I wasn't making contact with the eardrum. If I went any further I would have just dug it in and pulled it forward. You can see it's a bit yellow and greeny, it's really smelly. And there's the patient's tympanic membranes. It's still difficult to visualise because of the swelling, but I can see the handle of malleus. The eardrum itself is slightly inflamed. The patient also had glue ear, otitis media with effusion. So you could hear a lot better than when he first came in, but his hearing still wasn't 100%. Not only because of the swelling, but there was some fluid behind the eardrum called glue ear, acute otitis media. So I've given him some treatment. It was impossible to diagnose that before for myself or the ENT because you just couldn't visualise the eardrum, but I did a pressure test and we were able to diagnose that, so I've given some treatment for that. So I'm just mopping up now. We did so much, I just wanted to get as much debris, infection out of the ear to stop it from coming back really, despite the patient having 10 days extra repeat prescription. Sometimes with an infection, sometimes the best cure is just to remove as much, and it's not possible to remove every little last speck, but if you can remove as much as it's safely able to, that itself can sometimes help an infection and stop it in its tracks. So just some dead keratin, just peeling it from the roof of the ear canal. We've just got to be careful as well. The longer we're in the ear, because it's swollen already, we can increase that swelling the more we kind of are in the ear. So I just want to do it as quickly as possible. So I don't want this ear canal seizing up again, like last week. Brilliant. So, and you'll see a before and after shot in a moment. I think that went down well in my last video. So that's how the patient attended. And when he came 7 weeks ago, you couldn't see that even. It was that swollen. So it was a lot better today. And that's, you can see the swelling. You can see the eardrum clear. That's all clear. Same patient, just the right ear. So you can see, again, this ear canal wasn't as swollen as the left side last week. It was still swollen. So it's still swollen today, but not as badly as it was last week. But out of the two ears, this is the less swollen. He's just got discharge and disinfected dead skin right on the eardrums. We have to peel this off. So not a lot of people really enjoy the skin peels, especially off the eardrum, and more so when they're infected. And again, after I finished procedure, I performed tympanometry, and the patient also had glue ear on this side. So unfortunately, he's got an outer ear infection, which is the otitis externa, which is the infected debris in the left ear canal, and the swelling and the infected dead skin on the right side. So that's the outer ear infection, otitis externa, but he's also got a middle ear infection called glue ear. So again, I've given him some treatments. He's due to see the private ENT consultant, I think again, about 2 days ago to get the repeat prescription. So that's 10 days dose. So the next 8 days, and the treatment I've advised is for 7 days. So hopefully when he does see the ENT, just in case I need to give him some other type of antibiotics or repeat the dose, the glue ear would have improved. So yeah, you can just see I'm just peeling off keratin. Again, just going to be really cautious and gentle. The eardrum is only a millimetre in thickness, so it's very easy to perforate, especially at the top, the roof of the eardrum, the attic region, what we call the pars flaccida. So just tugging away at this infected skin. Again, this ear was really smelly as well during the procedure. Kind of got used to it actually. When I first started as an audiologist, as a training audiologist, and at that stage I wasn't doing earwax removal or any sort of clinical ear care. We was mainly doing hearing aid work, and when patients come in with ear infections and they take their mould out of their ear, you can smell it, and it used to make my stomach churn. It really did. I know my clinic manager Tracy absolutely detests the smell, because when someone comes in with an ear infection, you can just whiff it around the clinic. It's that bad. And Tracy, bless her, she really, really detests the smell. I'm sure anyone would, but I think I've just become immune to it. So she's got her own stash of air freshener. We open all the windows after a patient who's got ear infection. So we can see the anterior portion of the eardrum, the front part. So there's still a bit of debris around the edge. And continuing with the procedure, it wasn't necessary to improve the patient's hearing. I think the hearing at this stage, and when I complete the procedure, wasn't much different. Is when you've got an infection like this, if you can try and get as much debris as possible. I'm not encouraging someone to get all of it out. It's just as much as you can, safely as possible, because we don't want to try and clear this debris out and then we cause a perforated eardrum. So you're in search of kind of curing one pathology issue, and you create another by trying to do curing the first. So that's where a good practitioner kind of knows when to stop as well. And we're just, yes, but sometimes the best treatment alongside with the medication and avoiding water. Water is so important, guys. Avoid water in your ear. Water's the kryptonite of the ears, the arch nemesis. So if you avoid water, if we can clear this debris as much as we can, that'll probably give them the best opportunity for this infection to clear on its own accord with the assistance of some medication. So on the bony part, so there's less swelling here, so we do have to be a bit more careful in this ear not to make contact with the left side, because it was a bit swollen, and that almost gives like a buffer effect. It provides us with some resistance if we do come in contact with the bony part. So just posteriorly, inferiorly, there's still a bit of dead skin and dead infected debris there, so we need to peel that off. It's a bit of a tedious procedure. The fine end kept getting blocked because the dead skin is really gooey and thick, and it doesn't travel up the fine end. It keeps blocking it, so it kept coming out of the ear and unblocking it. And that's important when to know it's unblocked, because otherwise you run the risk of like just putting the fine end further and further into the ear. If you think, oh, it's not vacuumed, am I on the dead skin? And you go in further, but it's just blocked. So you've got to be careful, because if you're going too far with the fine end thinking that it's not blocked and you've not made contact with the debris, you could just go through the eardrum. So when we perform the procedure ourselves, I do anyway, I always keep one ear on the noise inside the ear, the suction probe. It can tell you a lot. So if it just goes mute, then you know it's blocked, so it needs to come out. If it's a loud sound and it goes quieter, so it's still audible but it's quieter, then we know we've got a suction grip and it's game on at that stage. So yeah, it just removes some dead skin posteriorly. So it's really important for the clinical ear care specialist to keep tabs on the loudness of the suction probe, because it does tell a lot. You can see the top part of the eardrum there, it's a bit wobbly, it's a bit bouncy, so that's when I had my suspicions that he's also got a glue ear, otitis media in the side. So there is fluid behind the eardrum here, because the eardrum itself is slightly inflated and inflamed. Just gently on the surface, so you can see here, this is the wobbly bit. So there's fluid behind there. So just kissing the surface, just I don't want to puncture that, otherwise fluid will be draining out. So it already looks a lot better than at the beginning, but it's still a bit more patient, wasn't any discomfort, so I decided to continue. There's just a bit of dead keratin superiorly. There's the superior quadrant, just want to peel that. It's just some in the anterior recess. I'm not sure if I get this out in the end. Let's have a look. I can't remember. It's just going to be really, because I'm going up, I just don't want to go up and into the eardrum and tear it or bruise it or cut it. So yeah, I managed to get that. It's still a bit left there, but again, at this stage I'm quite happy with what we've done, if I'm honest. Patients still not hear 100% because they've got this middle ear infection as well, but can hear significantly better than when they first attended. I think we've given a good chance for this infection to clear now, because most of the infected debris is out. So I'm just mopping up a bit of dead skin around the edge. So again, we've got to be careful in that region because it's the bony part of the ear canal, and it's almost like snake scales at the roof. It's really, so all this was discharge initially, and this discharge had coated the ear canal, and then the patient has been using the medication and it causes this discharge to crystallize. Sometimes it comes out in a cast of the ear. You suction and it comes out in one big cast. So again, just sort of up that. Again, we don't want to cut the ear canal, the lining of skin, because then that's going to introduce another infection. So we're again trying to treat one infection causing another. So there's the patient's eardrum, just a bit bulged superiorly. There was a bit of fluid there, we suspect. So that's the before, and you'll see the after image. Well, I hope you enjoyed that video, guys. I had another good one today that I wanted to upload, but it would have made the video too long, I believe. So I'll try and upload that during. Well, I've got some clear wax training tomorrow.